Good evening, friends. Very happy to see you. At the outset, I apologize for the 10 minutes delay in the start of the program due to technical challenges which we face. I hope we always give you the best of the academics, and we also want the best of the connectivity and without challenges. Kindly apologize for all of us for the delay for today's IAGES prime time. Friends, IAGES prime time is almost now 2-year-old baby. We have seen various experts, various subjects, various stalwarts, and people who have made groundbreaking research, translational science, academics, great surgical craftsmen, and visionaries and pioneers who have contributed to the IAGES prime time. Today, as we move on to various subspecialties, this turn is for bariatric and metabolic surgery. We have very important faculty across the globe and from our own country being part of this academics. May I have the honor of welcoming our president, Professor Dr. L.P. Thangavelu, sir, to give his presidential welcome. Over to you, sir.
Good evening, my dear friends. Good evening, Past President Ramon Narwaria, Manish, Secretary Satish, and Randeep, and good evening, all the viewers. It gives me great pleasure and happiness to be here in this IAGES prime time. IAGES prime time is a very popular program of IAGES, online program of IAGES. Been conducting this program for the past 2 years, and several stalwarts, giants in laparoscopic surgery, minimal access surgery have participated in this program. You all know IAGES is a primary association in minimal access surgery in India. Started way back in 1993, and more than 9,000 live members are life members in IAGES, and we are involving ourselves in various academic activities. The prestigious fellowship courses, basic laparoscopy courses, FIAGES, and advanced laparoscopy courses, FALS program, fellowship in advanced laparoscopic surgery. And FALS programs, we have been, in FIAGES, more than 4,000 surgeons, young surgeons, have passed out fellowship in basic laparoscopic surgery and advanced laparoscopic surgery. More than 1,000 people have already, got the fellowship after rigorous training and strict examination. And, the IAGES, all the past presidents and secretaries are actively involved in promoting bariatric surgery from the beginning. If there are about 100 or 150 bariatric surgeons, popular bariatric surgeons in India, almost all of them are IAGES members, are past office bearers, and worked in various capacity and responsibilities. Even in the last year also, we have every year, certainly we are having a PALS bariatric program. This year, our renowned bariatric surgeon, Dr. Raman, is the PALS board chairman, and we are having a PALS bariatric course July 789. Am I right, Manish? 789. And in Ahmedabad.
8, 9, 10. 8, 9, 10.
Yeah, 8, 9, 10. I'm sorry. 8, 9, 10. So we are going to have a wonderful, great time at Ahmedabad. And with this, I welcome you all for the National Congress to be held at Coimbatore, 2023, February 9, 10, 11. And there also in all our National Congress, we are having a separate bariatric hall and bariatric live. We give a lot of importance to bariatric surgery as well as live surgery and panel discussions. A lot of discussions will be held in our National Congress. I welcome you all for our National Congress to be held in February at Coimbatore. With these few words, already we are late. Let us move on to the business. Thank you. Kanavel, you are not audible.
Thank you, President. Thank you for this inspiring words. And as you have mentioned very ably, the most of the pioneering work in Indian bariatric and metabolic surgery has happened from the members of the IAGES. And in fact, many of them have become pioneers on their own. And the Bariatric Society of the India, the OSSI, is a brainchild of the IAGES members, and later now they are in the global arena of the IPSO. So as we get to go ahead with the program, for the benefit of the participants, the program have two halves. One is the invited talk by Professor Nimeri, followed by we have a most eminent panelist, bariatric exponents from different part of the country, where none other than our past president, Dr. Ramon Goel, is going to moderate a unique video session on challenges and difficult situations in bariatric surgery. Friends, let us have the honor of inviting Professor Nimeri. Can I request our Honorary Secretary of the National IAGES to do the honors? Dr. Mida, please. Satish sir. Okay. So, ladies and gentlemen, it is indeed a most pride moment for all of us to introduce Professor Abdelrahman Nimeri. He is the Secretary, Treasurer, and past President of the IFSO, the World Federation of the Society of Obesity, MENAC, and PASMBS. He's right now the Associate Professor and Chief, Bariatric Surgery, Carolinas Medical Center, ATM Health, and he also serves as the Director, ATM Health Weight Management, Director, Carolinas Bariatric Fellowship Program, and he is the Diplomat of the American Board of Obesity Medicine. He also serves as an Associate Editor, the Obesity Surgery Journal. He was earlier working as the Chief of Division of General Thoracic and Vascular Surgery, Director of Bariatric and Metabolic Institute, Abu Dhabi, and he is also the Surgeon Champion of the ACS National NSQIP at SKMC. In addition, he is the lead surgeon for the Middle East Collaborative of the ACS NSQIP program, which was established way back in 2016. He is also an adjunct staff at the Cleveland Clinic Endocrine and Metabolic Institute in Cleveland, Ohio, and also serves as an adjunct associate clinical professor of surgery at the UAE University. Professor Nimeri was associate program director of the first ACGME 1 accredited surgery residency program in the Middle East at the SKMC in Abu Dhabi. And he also serves as the Fellowship Program Director of the MAS and the Bariatric Surgery Fellowship Program at SKMC. Professor Nimeri is the Secretary Treasurer of the IFSO Communication Committee and past President of the Pan-Arab Society of Bariatric and Metabolic Surgery. Ladies and gentlemen, it is a pride and privilege for the IAGES, and I welcome Professor Nimeri on behalf of the President and the entire member fraternity of the IAGES. Can I have the honor of inviting Professor Nimeri to give his talk, please? Over to you, Professor Nimeri. Welcome.
Thank you very much for the kind introduction. Can you hear me?
Pretty much well, sir.
Very good. So I'm going to try to share my screen. Let me know if you can see it.
Yep.
Okay. So it says my stop share. I'm going to try it again.
Yes, sir.
Right. Okay, do it one more time. All right.
Yes.
Can you see my screen right now?
We are able to see your desktop, sir.
Do you see the talk or not yet?
We are yet to see. Yeah, now we got the talk on, sir.
Perfect. Great. So thank you again for the kind introduction and the kind invitation to participate with you today. So I was asked to speak about how to prevent complications after bariatric surgery. Some reason I am not seeing the screen. Can you see it yourself?
Not yet, sir. Not yet.
Oh,
Okay.
I think it is going full screen and it's taking little time.
Okay. How about now?
This is better. Yeah.
Yep. Done, sir. You're good.
Perfect. So this is my disclosure slide. It has no bearing on the presentation, but it just shows that Runway gastric bypass represents more than 60% of my practice. I'm going to try to cover 4 main points. How to prevent and manage leaks in both forms of gastric bypass, Runway and one anastomosis, as well as in sleeve gastrectomy. Touch a little bit about surgical skill when you compare both sleeve and Runway gastric bypass, and then talk about some technical complications, mostly in Runway gastric bypass, but few points in sleeve gastrectomy. And then conclude by talking about 2 important things that are not surgical in nature, but could affect our patients: venous thromboembolism and sleep apnea. So this study is a review of 100 medical legal cases that was done several years ago. Most of the cases were Runway gastric bypass because at the time, most of the surgeries were Runway gastric bypass. And if you notice that 86% of the complications were either leak or collection signifying a leak and or bleeding. And the rest you can see bowel obstruction, airway, but 8% was pulmonary embolism. So let's start by talking about leak and the importance of proper patient selection. This is a study from the MBS-equipped data set, and it shows 133,000 participants. And in this study, you can see that the overall leak rate is low, but the factors associated with an increased leak are high-risk patients: sleep apnea, low nutrition, oxygen dependency, hypertension, and diabetes. So it is important that for some patients you offer sleeve gastrectomy because they're high-risk patients. So for instance, someone who's older, cardiopulmonary status is significant, someone with renal insufficiency, patients with large abdominal hernias, and patients on chronic anticoagulation. Not necessarily for atrial fibrillation, but for either a mechanical valve or pulmonary embolism or VTE. I think those patients preferably should undergo sleeve gastrectomy. Sleeve gastrectomy is a very good operation for high-risk patients. The other important thing, especially for the juniors in the crowd, if you have patient who has tachycardia and you CT them and the CT is negative, that patient needs the ultimate diagnostic test, which is a diagnostic laparoscopy in the operating room. That's not considered surgery. It's considered a test that is superior to CT scan to make sure that you don't miss someone with a leak. Now, why is this important? Because if you look at the video on the left, compared to the video, sorry, videos didn't run. See if I can get the videos to run. For some reason the videos didn't run, but if you compare the leaks, leaks that are delayed present very aggressively compared to leaks that are taken care of early on. And that's why it's important to get leaks taken care of early. So for instance, if you compare leaks after Runway gastric bypass to leaks after one anastomosis gastric bypass, this is a large study that was published in 2017 in SWORD from the group in France after one anastomosis gastric bypass. They had 17 patients who had a leak. Most of them, the leak was at the gastrojejunostomy. But I think what's important from this study is that most of the patients needed surgical management, 16 out of 17, or more than 94%. But also they compared patients who had emergency conversion to Runway compared to delayed conversion, and the morbidity rate, which is in general around 40%, was the highest in the delayed group, 83% versus 16%. Length of stay was also much longer in the delayed group. So it appears because one anastomosis gastric bypass causes biliary peritonitis, you might need to treat the leaks more surgically and maybe in an expedited fashion convert the patient to Runway gastric bypass. So leaks after one anastomosis gastric bypass are different because they might need conversion to Runway, because surgical management might be needed more than Runway, because they cause biliary peritonitis, and because a gastrostomy or a jejunostomy tube might not be as effective with the setup of one anastomosis gastric bypass. Because if you put a G tube, it's still, the feeding is going to go across the anastomosis, and if you put a J tube, like unless you do it well, you might have problems at the biliopancreatic limb. Also, endoscopic stents might not be as effective. You could still place endoscopic stents, but the risk of migration is higher. So when someone has a leak after one anastomosis gastric bypass, they are a different breed and needs to be treated differently. So if you look at these two videos, the video in the top left is how to place a G-tube. Video in the bottom right is how to place a jejunostomy tube. They are different. Why are they different? To place a G-tube, you just have to place a purse string, place a Foley catheter, and you don't even have to attach it to abdominal wall or stam it, because it's excluded, that stomach, in a Runway gastric bypass. But in a jejunostomy tube, as you can see in the bottom, after placing the tube, you have to Witzel it, create a Witzel tunnel, and you have to attach it to the abdominal wall in two places so you don't have a kink. So a jejunostomy tube is different, so you might need extra ports and you need to secure it to the abdominal wall. The other thing that's important when it comes to leaks is to test the anastomosis. It's important if you do a gastrojejunostomy, whether for Runway or for one anastomosis, or if you do it for a SADI or a DS, that you test the anastomosis either with endoscopy, or you could do it with methylene blue or another way with air. But it's important to test the anastomosis to make sure that the person doesn't have a leak before you leave the operating room. And in the 100 medical legal cases I talked to you about, the prevention of leaks and their timely diagnosis was the single most important strategy to improve patient outcomes and prevent malpractice lawsuits. So, one of our mentors when I was in residency used to tell us that if you go to the mountain often, you'll meet the tiger. This is a Chinese saying. And I think that study, this study I'm showing you is a survey of patients who are sued in the US who are SMBS members, and the probability of medical malpractice lawsuit correlates positively with the numbers of procedures performed and the numbers of years a surgeon is in practice. So you really cannot avoid getting in trouble with patients, but you will get in trouble if you don't talk to your patients about the potential of having a leak. You'll get in trouble if there's a delay in diagnosis. And in that study, 15% of the time, the surgeon who took care of the leak was not the surgeon who operated on the patient. So you really can't plan on not having complications, but I think you need to discuss them with patients and their families. Now, why is it important to discuss with families? Because when someone has a leak and they're sick and they're in the ICU, you're not going to be talking to them. You're going to be talking to their spouse or their son or their father or their mother or their a child. So it's important to have a good relationship with the family, and it's important to follow your own guidelines. So, for instance, you must have heard that this week ASMBS finally approved one anastomosis gastric bypass. So surgeons in the US can do it. But before that, even though I could do it when I was in Abu Dhabi, I was not allowed to do it when I came in the US, because if you don't follow your own guidelines where you practice, you could get in trouble with medical legal cases. And it's important to show patients in a way they understand what are the options, what are the potential complications. And it's not enough just to use diagrams like this. Today, we have things like this MBS-equipped bariatric surgical risk-benefit calculator. This is available to any one of you. At home, you could go to this website you can see in front of you, and I do this for every single patient. And you can actually show the patients based on their age, BMI, gender, and medical problems, what is the rate of dying in each surgery, any complications, serious complication, leak, bleeding, infection, reoperation, readmission, and reintervention based on the MBS-equipped risk calculator. So it's also important to talk to your ER physicians and make sure that your ER physicians, when someone shows up, that it's not missed, that if someone comes up with vomiting, that they get thiamine, that if someone shows up with tachycardia, that they get a CAT scan, then an abdominal X-ray. Now, is this important? This is a very elegant study now that's 16 years old from the group in Michigan with a concept called failure to thrive. So what is this concept? Failure to thrive means that when patients die after surgery, it's because you failed to rescue them. So this is a study where you can see these 4 bars represent 300 hospitals, and the bars in number 1 have a mortality rate of 3.5%. The bars in number 5 in black has a mortality rate of 7%, while the complication rate in all the hospitals is the same. But the mortality is very different because some hospitals fail to rescue their patients. So it's extremely important to make sure that you're expedient in taking care of patients. I'll give you one example. So when someone has bleeding in surgery, especially in laparoscopy, it's important that initially you secure the bleeding by just packing it, similar to how in open surgery you put your finger on the area of bleeding. And then at that point, you have to stop and discuss with your anesthesiologist, make sure you have proper IVs, make sure the patient has blood available, make sure your assistant is the proper assistant, or maybe get a proper assistant, make sure you have all the instrumentations you need, maybe upsize a port or 2 so you can put more packing, and maybe get better suction. And then the most important thing is if you decide to open, you need to pack the area of bleeding from a lateral port and make sure that you can hold pressure, that there's no bleeding from that lateral port, regardless of whether the bleeding is from a splenic vessel or from short gastric, and then open in a controlled fashion while the patient does not have hemorrhage. This is extremely, extremely important. So let's look at technical skill. So for instance, this is a study most of you have seen that was done several years ago from the group in Michigan, the Michigan Collaborative, looking at technical skill in bariatric surgery. What they did is they asked 20 surgeons to submit their best video of creation of the gastrojejunostomy and the jejunojejunostomy edited in Runway gastric bypass. And they had independent reviewers rate those videos in terms of how general is the surgeon, time and economy of motion, instrument handling, flow of the operation, exposure, an assessment of an overall technical skill, and then summary. And what they did is they put surgeons into quintiles of poor performers, in the middle, high performers. And you could correlate the risk of developing any complication surgical complication, even medical complications to technical skill. You could correlate reoperation, readmission, and ED visits to technical skill. So in this study in Runway gastric bypass, they were able to show that if you rate a surgeon as technically in the best quintiles compared to someone in the bottom quartile surgeons had higher complication rates, higher mortality. They had longer OR time, higher reoperation, and higher readmission. Now, what's interesting, so in this study, they concluded that there's a wide variation in technical skill of surgeons performing Runway gastric bypass, even when they provide their best video. And it seems like technical skill in Runway gastric bypass is a predictor of outcomes. So the group did another study looking at the same videos, but comparing the outcomes of sleeve gastrectomy of the same surgeons. And to their surprise, there was no difference between surgeons in regard to leak, obstruction, infection, bleeding, VTE, or medical complications in sleeve gastrectomy, even in the bottom quartile surgeons. And there was no difference in medical or surgical complications in sleeve gastrectomy as it was in Runway gastric bypass. There was no difference in reoperation, readmission, or ED visits. So it seems like surgical skill and OR time matter more in Runway gastric bypass, but not in sleeve gastrectomy. And in another study, they even looked at OR time. So OR time is another predictor. Slower surgeons do the surgery an hour longer, and they have more complications, more long length of stay, and more VTE. So to me, it is no surprise that surgical skill affects outcomes in Runway gastric bypass, but not in sleeve gastrectomy. Now, if you think about it, both of them are done in patients who have difficulty of exposure. But in sleeve gastrectomy, you only perform resection. And most surgeons who don't oversew don't have to do anything else. But in Runway gastric bypass, you have to do resection and reconstruction. And it is technically more complex than one anastomosis gastric bypass because it has to be done above and below the colon. And as I will show you, many of the complications of Runway gastric bypass are technical in nature. So let's look at these technical complications of Runway gastric bypass and take a look at them. So if you ask most surgeons, how big do you make your pouch in Runway gastric bypass, they will say 15 to 30 milliliters. But if you ask them how do you measure it, they might not be able to come up with an answer. And the group in Scandinavia has actually shown us that you need to use not more than 3 cartridges to create the pouch, as you can see depicted in the picture here. So if you look at this video, this is how we create our pouch in this very, very short video. So the most important thing we do is, video is not running yet. Okay, let me see. So now it's running. So the most important thing we do in the creating the pouch is we measure from the lesser curvature where the GE junction is and the angle of His where to create the pouch. We go between the neurovascular bundle and the stomach, so we preserve all the vagus and vessels, and then we use 2 cartridges to create the pouch alongside a 34 French tube, and we hug to that tube. So it's important when you create the pouch that you have a way by which you objectively measure that pouch. Why is that important? This is a very elegant study from Brazil that compared the size of the pouch with outcomes. So what they did is they looked at 67 patients who were approximately 4 years from gastric bypass, and they looked at the pouch size measured by CT volumetry and pouch emptying measured by scintigraphy, and looked at the retention and the emptying. And they found that the pouches that are less than 40 cubic centimeters had the best emptying and had the best weight loss, least amount of weight regain without causing any dumping measured by mixed meal test. And we've done a similar study recently looking at the pouch size by CT volumetry in 2 matched groups looking at marginal ulcer. And we found that a larger pouch of about 34 cubic centimeters has a larger prevalence of marginal ulcer or incidence compared to a smaller pouch of about 20 cubic centimeters. And each 5 centimeter increase in pouch size leads to more than 2.4% increase in the risk of developing marginal ulcer. So you could actually detect the pouch size by CT volumetry accurately, and it correlates not only with better emptying, as I showed you in the previous study, but in our study of 122 patients, it also correlates with the risk of developing marginal ulcer. Now, what are other technical complications in Runway gastric bypass? Let's look at stricture or marginal ulcer. So our group looked at more than 1,000 patients in our group who had surgery. Some had circular, some had linear, some had robotic hand sewn. And we compared the number of patients who had an endoscopy. And we found that the rate of endoscopy was much higher in the circular stapled, 19.9% compared to 13.9% in linear. The rate of marginal ulcer was almost double in the circular. And the rate of revision for marginal ulcer was also higher in circular stapled anastomosis, even though the surgeons were using 25 millimeter EA to create the anastomosis. Similarly, we looked at the rate of stricture, and it's a very similar story. The rate of stricture was much higher in the 25 millimeter circular stapled anastomosis. Now, a previous randomized study has shown that 25 millimeter has a lower stricture rate than 21, but in our hands, even 25 millimeter has a higher stricture and marginal ulcer rate than linear stapled anastomosis. So clearly, the rate of developing complications of gastrojejunostomy is related to technique. Now let's look at the jejunojejunostomy. This is a very interesting study from the Scandinavian registry, where they had patients with chronic abdominal pain that's unexplained, and they felt that the jejunojejunostomy was the problem. And in more than 100 patients, when they revised that jejunojejunostomy, the patient's pain improved after just revising the jejunojejunostomy. So the way the jejunojejunostomy is constructed could be one of the reasons people have pain. And we published the largest series of intussusception in the literature. So we reviewed more than 2,300 gastric bypasses from our practice and identified 34 jejunal intussusceptions. Some surgeons in our practice do different techniques to create the jejunojejunostomy. And we found that the single predictor that could correlate with developing an intussusception was the double staple technique. The 120 millimeter jejunojejunostomy has a much higher rate. But we also found that jejunojejunostomy intussusception tends to recur if you just reduce it. And even it recurs if you just pexy it. And in our practice now, if someone presents with a JJ intussusception, we try to revise the jejunojejunostomy to a single firing to prevent it from recurring. And this is just a video showing our own technique of performing the jejunojejunostomy with a single stapled fire. What we do is we make sure that when we start close to the mesentery, so you have more bowel to work with, and then you use a single fire of a white load to create the jejunojejunostomy, and then we close it with suture and then close the mesenteric defect. Another complication that we know is related to developing like in gastric bypass is the complication of someone having an internal hernia. So for instance, a large multi-center randomized controlled trial from Sweden published several years ago has shown that when you compare patients in blue who did not have the hernia defects closed after gastric bypass, Runway, to patients in green who had it done, you can see that there's a tremendous difference in the rate of bowel obstruction or internal hernia. But initially, the patients who had closure had a higher rate of obstruction at the beginning because most likely of learning curve. So it's important that when you close these defects that you use a proper technique. And for the sake of time, I'm just going to keep moving. Now, in sleeve gastrectomy, there are less technical issues that can cause problems. But obviously, the bougie size makes a difference. taking care of the GE junction not to be too close, taking care of the incisura not to be too close, and then deciding what to do about the staple line and using an intraoperative endoscopy. And I just want to show you one important thing about how to suture. So there are two studies in vitro that showed that the way of suturing like this, like a baseball suture, actually weakens the staple line. I think the better study is this study from Phil Shower's group, where they randomized 30 specimens of sleeve gastrectomy to either do as the right picture, suturing like a baseball stitch, Lambert on the left picture, or leaving it alone. And the highest leak rate was in the baseball suturing, even higher than leaving it alone. And the lowest was actually the Lambert suturing. So if you suture, you need to do Lambert suturing. And for the sake of time, I'm gonna just proceed to the last portion of the talk, which is venous thromboembolism and sleep apnea. So if you remember those 100 medical legal cases I showed you, 8% of them were from pulmonary embolism. And I think it's important that you pay very, very close attention to pulmonary embolism. Number one, it is the number one cause of death after bariatric surgery today. So the 30-day mortality, if someone had a VTE, is between 2.6 and 8.6%. This is compared to a 1 to 3 in 1,000 mortality after bariatric surgery. And if someone develops a pulmonary embolism within 30 days of surgery, this is the strongest independent predictor of dying 1 year after surgery. So pulmonary embolism is something you need to really pay very close attention to. The mortality rate is 25 times higher if someone developed a VTE compared to someone who did not develop a VTE. And in this study from published in the Annals of Surgery by Ali Aminian's group from ACS NISCOIP, you can see that DVTs and PEs continue to occur up to 30 days, but the vast majority happen in the first 2 weeks after surgery, and 80% happen after discharge from the hospital. We've looked at more than 1,100 patients in our practice when I was in Abu Dhabi, compared them to US patients, and we found that in the initial portion between 2010 and 2012, when we just had a fixed way of dealing with venous thromboembolism, we had high VTE rates. But once we had a way by which we risk assess everyone, our rates decrease over time. So what I will tell you about VTE is you cannot use a fixed dose VTE prophylaxis for all patients. You will miss patients that way. You need to identify which patients need extended prophylaxis after discharge. And in our strategy, we use the Caprini risk assessment for everybody. Most patients get Lovenox, not sub-Q heparin, because the Michigan collaborative study has shown that Lovenox is better than sub-Q heparin without an increased risk of bleeding. And in patients with a BMI over 60 or BMI over 40, we adjust the Lovenox dose from 40 twice a day to either 40 once a day if the BMI is less than 40, or maybe 60 twice a day guided by anti-factor 10A if the BMI is over 60. Other important thing is to look for sleep apnea. I think the Stop Band questionnaire is a very easy way that you can do looking at sleep apnea. Why is it important? Because a study published from the Labs Consortium showed that sleep apnea is a predictor for an adverse outcome after bariatric surgery, and it's a predictor of higher mortality. So in conclusion, what are the take-home messages? I think sleeve leaks are more difficult to treat than gastric bypass leaks. They take longer time to heal. The sleeve is a higher pressure system as shown by manometry studies. It has a pylorus which acts as a distal obstruction. And the sleeve leak needs a jejunostomy tube, which is more difficult to perform. One anastomosis gastric bypass leaks lead to biliary peritonitis. They're not as easy to place a gastrostomy tube in a one anastomosis gastric bypass. And most of them, as I showed you from that study from France, need conversion to Runway early. That's why you need to treat one anastomosis gastric bypass leaks differently. But in general, you cannot plan on not having a leak. You need to plan on diagnosing the leaks early and have a clear plan to manage them. You need to discuss the potential of having leaks with patients and their families, especially high-risk patients. And you need to think drainage, enteral feeding, not parenteral feeding, and be patient, especially in sleeve gastrectomy leaks until they heal. You need to test any anastomosis before you leave surgery. Another take-home message to prevent complications is to screen every patient for sleep apnea using the stop bang questionnaire. And another important take-home message is think of venous thromboembolism. 80% of them happen after discharge. It's the #1 cause of death, pulmonary embolism after bariatric surgery. Use Lovenox, not sub-Q heparin. Don't use a fixed dose, but rather risk-assess patients. For patients with BMI over 40, use 40 twice a day of Lovenox, less than 40 once a day, over 60 BMI or over 150 kilograms. Check anti-factor 10A before surgery. Give 3 doses, 4 hours later, check an anti-factor 10A with a goal of 0.2 and 0.4. And then finally, you need to know that most Runway gastric bypass complications are technical in nature, and that technical skill is extremely important in Runway, even more important than sleeve. So as a program, you need to make sure you establish smoking cessation to minimize complications, set up an MDT team. And I think for surgeons who are starting in practice, I recommend that you don't start with high-risk patients. Don't do revisions first, don't do males first, don't do patients with BMI over 50. I'm going to stop there, and I want to thank you again for the opportunity to present today.
Professor Nimeri, it's been a pleasure listening to your wisdom. I'm sure you compartmentalize the issues to make it presentable.
I think you're muted.
Am I audible, sir?
Yes.
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 Thank you, Professor Nimeri. President, your comments, please.
Yeah. Professor Nimeri, it was an excellent, presentation, and you analyzed your analysis and presentation extremely, will be appreciated by anybody. Thank you. I extend, before they go to discussion, I extend my invitation to our national conference to be held at Coimbatore in February 23, February 9, 10, 11, 23. Thank you, Professor.
Thank you. Thank you for your kind words, and it will be my pleasure to join you in Coimbatore.
Thank you.
Thank you, President. Professor Nimeri, to start the ball rolling, if I can ask you one question. With so many guidelines around, and you just now announced that one anastomosis procedures have also been approved by the board. It looks like we are compartmentalizing the type of procedure based on the BMI, and it's going to be soon individualized decisions for bariatric. And I'm sure already many institutions like Dr. Rahman, Dr. Manish, and Dr. Narwaria and others, they have got multidisciplinary board to make decisions. So how well they are planned. So what is your take on the multidisciplinary boards and its influence on the type of procedure? Because you very clearly disclose that you are more as a bypass man. But then does it mean is it also equally influenced by your multidisciplinary board, or still the bariatric world goes by their own choice of the procedures? How do you take this question, Dr. Nimeri?
I think this is a very important question, and I like in the U.S. the MDT discussion does not guide procedure selection like tumor board in cancer, and I think it should. It should. Look, today, if you're a cancer surgeon and you have a patient with gastric cancer or rectal cancer or breast cancer, you as the surgeon cannot decide the timing of the surgery, nor you can decide the type of surgery. Most of the time, your radiation oncologist, your medical oncologist, your pathologist participate with you in that discussion, your radiologist. And today, we don't have enough obesity medicine specialists to be able to guide that discussion. We don't have geneticists in our team to guide that discussion. Our pathologists don't even look at our sleeve gastrectomy specimens to see what the patients have. So I think in the future, if you look at a futuristic view, absolutely. But if you ask me what I do for my patients, Runway gastric bypass is not a good operation for high-risk patients. Sleeve gastrectomy is better. Roux-en-Y gastric bypass is not a good operation for someone with a BMI over 50, especially over 55. One anastomosis or duodenal switch is better. And finally, Roux-en-Y gastric bypass might not be the best choice for a low-risk patient. So if someone has a BMI of 40, they have no diabetes, they have no reflux, I mean, a sleeve gastrectomy will get them exactly where they need to go. So you need to select and choose depending on the patient.
Thank you very much. May I have the comments from our past president and single specialty bariatric surgeon, Professor Ramon Goel, please.
Professor Nimeri, a pleasure to listen to you, and such an eye opener on the risk prevention or the complication prevention in bariatric surgery, because there is so much evidence available to guide surgeons in the various aspects of bariatric surgery, as you mentioned. But I'll take the question that Dr. Kanagwil was asking further. He called you a bypass surgeon, and now there are MGB surgeons and there are sleeve surgeons, and everybody says that, you know, we find a procedure as per the patient, but are there any guidelines which guide surgeons according to the BMI or according to diabetes or whatever? Are there any guidelines to guide surgeons for a particular procedure?
Sure. So let's think of diabetes. So the diabetes surgery guidelines evaluated gastric banding, sleeve gastrectomy, gastric bypass, and duodenal switch. And the guidelines at least made a recommendation that the best benefit-risk ratio for someone with diabetes is probably Roux-en-Y gastric bypass, unless there is another reason. So if you're a high-risk patient, maybe you'd accept sleeve gastrectomy. So at the end of the day, so that's clear. The two randomized control trials, the study from Switzerland and the one from Finland, has shown, especially the one from Switzerland, the SMBOS study, that Roux-en-Y gastric bypass leads to less reflux compared to sleeve gastrectomy. So generally, if someone has Barrett's esophagus or severe reflux, they should not have sleeve gastrectomy. They should probably have Roux-en-Y gastric bypass. Should not even have one anastomosis gastric bypass. I think the most important item is the technical comfort of the surgeon. So I showed you that the skill matters more in Roux-en-Y than sleeve. If a surgeon is not comfortable doing Roux-en-Y gastric bypass, they should not do it. They should offer the patient what they're comfortable with, but they have to level up with the patient. So meaning, if a patient has reflux and they're diabetic and they're coming to see me, and I'm not comfortable doing Roux-en-Y gastric bypass, I should tell them, you know what, maybe I'm not the best surgeon to take care of you. But does that happen? I doubt it does.
Yeah. I think that's such a valid argument. And you know, we just met you about 15 days back in Bangalore, and it's a continuity of your talk there. So thank you so much. I'm sure other panelists have some questions for you.
Yeah, I would like to ask you one question, Dr. Nimeri. Roux-en-Y gastric bypass, technically, yes, if you can do it, you should do it. And we have been doing it. Around 90% cases are Roux-en-Y gastric bypass. In the jejunal you said it should be near the mesentery, more near the mesentery. And we are doing it more near the anti-mesenteric border. And with so many cases, we have been very comfortable doing it without any problem, without any obstruction, without any intussusception. And as of now, I think there is no post-operative complication in any of our patients. Any reason to do near the mesentery? I just want to.
Sure. Yeah, if you're doing something and it's working, you should not change. I really think what you're comfortable with, guided by outcomes, is the most. I can tell you something I didn't present to you today that we've looked at, and we're going to present at the ASMBS meeting in Dallas next month. So we looked at the cost of sleeve gastrectomy and the cost of Roux-en-Y gastric bypass amongst 5 surgeons in our practice. And the cost of sleeve gastrectomy has very little variability between surgeons. And the number one driver is staple line reinforcement. The cost of gastric bypass has significant variability among surgeons. So that's why if you look at it from a population health, if you're the minister of health in a big country and you are only offering surgery to 1% of the population, you might not want to offer more of Roux-en-Y gastric bypass or one anastomosis. You would just want to offer sleeve gastrectomy. Why? Because it's cheaper, has less complication rate, and it's gonna get the most number of people more than 10% weight loss. That's very different than when you look at the individual patient, one at a time.
Very correctly said, and you are very right. You should not change if you're getting results from whatever you are doing. And I also believe in it. We listen a lot of talks with a lot of variabilities in Roux-en-Y gastric bypass or IAGES or whatever you say. But if you are getting good results, good, no complication or less complication, no complication is not the thing, less complications, we should not change. That is also my message to everybody, because if you are doing something which gives good results, less complication, should not be variated around too much. Thank you very much.
I agree, Manish, and again, congratulations on the very successful OSCON conference. It was really,
Thank you. I would remember you throughout. I have a photograph with you where I seem to be very small.
You need to send it to me. I don't have it.
I'll send you.
So, can I ask a question as well?
Yes, Randeep, please.
Yeah, hi, Professor Nimeri. Again, wonderful listening to you and a great talk as always. So you mentioned about the risk assessment. Now, this is something where you do a risk calculator, the MBS equipped calculator. Now, when I saw that bar chart, I also saw that there is risk of death. Now, what happens, I'm talking practical question here, that we in India, we are not doing 220,000 or 220,000 bariatric procedures. We are still in that nascent stage where probably we are doing 20,000 as of now. Yeah, we intend reaching there, but not as yet. And if you show those data that there is a risk of death as well, there would be a lot of deterrence. So this is a practical question which some may not agree, but this is practically there when you show this to the patient. How do you circumvent this?
Sure.
You know, or how's the journey been where these patients kind of accept these kind of complications upfront before going for a procedure?
I think this is an excellent question, Randeep, and I tell you, I practiced for 9 years in Abu Dhabi. The population in Abu Dhabi is very similar to the population in India. Risk averse, very emotional. They only want to hear what's going to happen that's good. I get it. But I tell you, I talk to everybody about death. How did we do it? We had a pre-printed sheet that had the benefits at the top, and it has the risks, and it includes a 1 to 3 in 1,000 chance of dying. Now, when someone asks me about death, I tell them that over the next 30 years, if you do nothing, your chance of dying is way higher than if you have the surgery, including the 3 in 1,000. And I can tell you the benefit of the risk calculator. And if you start using it, you will notice this benefit. I'll tell you an anecdote. You know, in life, the stories are more important than the randomized trials. This is a fact. So I had a lady I saw in my office. She's 68 years old. She's diabetic, has reflux. And when I saw her, I told her you should have Roux-en-Y gastric bypass. She agreed on it. Then in the pre-op visit, I reprinted the risk calculator. Her husband was there. So her husband looked at the complication rate and he said, this complication rate is high to me. Is there anything that is less complication? So I said, yes, there is something called sleeve gastrectomy. So he said, can you show us the difference? So I showed them the difference. So he asked his wife, what would you prefer more? That the diabetes is less resolved, the reflux is less resolved, but the complication rate is lower. And they decided that she will have a sleeve gastrectomy. Even though she's diabetic, She has reflux because it has a lower complication rate. The beauty of the risk calculator is it allows the patients and their family to engage with you and to make an informed decision. And because the risk calculator looks at patients who had surgery over the last 3 years, compares age, gender, BMI, all these things, it is a very reliable way of patients making a decision.
Thank you. Excellent.
Excellent, excellent, Dr. Nimeri. And actually, I got a patient today where the same question was asked to me. And then I answered in a different way, don't get the surgery. That is the best way.
Yeah.
Just on a lighter.
I tell you something Kelvin used to do that used to make me laugh. So after surgery, when Kelvin Higa will prescribe Actigol to patients, and patients say, oh, this Actigol is expensive, this Actigol doesn't taste well, he tells them, my #1 preferred operation is cholecystectomy. The second preferred is bariatric surgery. He tells them, you don't take it, you're going to come back with gallstones, I'm going to remove your gallbladder. That's my favorite operation.
Yeah, I definitely tell you, my favorite thing is not to do surgery. I'm a surgeon. I'll be more at peace if I'm not doing a surgery on you. You have to decide if you want to be at peace or not without having a surgery and have all complications together in your life.
Right.
Thank you very much, faculty. Professor Nimeri, thank you for sparing your valuable time with us this morning in spite of your busy schedule and contributing on towards the academics of the IAGES. On behalf of the president and the member fraternity, I thank you for joining us this morning from your side, and this is late evening in India. I also have a request. Do we have time to request you, or do we have time for you to stay with us for the panel which is going to follow after your talk? Or
Absolutely. I'll stay on.
Thank you very much, Professor Nimeri, for accepting our last minute request. Ladies and gentlemen, I think we are already half the panel done with the huge questions coming up from the floor. But it's my honor and responsibility to introduce Dr. Ramon Goel. In fact, friends, it is Dr. Raman's brainchild, what we are enjoying as a prime time over the last 2 years, which was Raman took over as the president as in the most difficult period of the entire world fraternity during the COVID era. But then IAGES evolved itself very rapidly towards various social activities and the digital mode of academics during his tenure. Dr. Raman hails from Mathura, and he has had a brilliant academic career in Mumbai. And he was one of the pioneers in bariatric operations, as well as he started as a single subspecialization towards bariatric operations. Raman, during his period of presidentship, brought in a lot of important initiatives on the research, on the JMAS, on various thesis awards, and he brought in the young surgeons into the ambit of doing research. And it was during his time, the IAGES started its own research wing. To its feather, we have more than 9 original research nationally and globally conducted by various subspecialties. Ladies and gentlemen, may I have the honor of inviting Dr. Raman to do the expert panel discussion on various challenging issues governing perioperative.
What happened? Good evening. I think Dr. Kanagwil got muted. So let me take over from here. And at the outset, I would like to thank the President, Professor Thangavelu, for the invitation and for continuing with the prime time in such a beautiful manner. And this academic activity has maintained a momentum in IAGES. I would also like to thank Dr. Satish Midha, the Honorary Secretary, and the entire Executive Committee. And on top of it, the curator of this program, Dr. Kanagwil, who has been relentlessly conducting this program for almost 3 years now with different presidents. So thank you so much. My job has been made easy by an excellent talk by Dr. Nimeri about how to prevent complications in bariatric surgery. And I have been asked to speak on perioperative challenges during bariatric surgery. So perioperative challenges is more of a technical issue, and for this talk, I'm not going to show you any slides because I have a very eminent panel. The one of the trustees of OSI, Dr. Mahendra Narwaria, who is also the past president of OSI, and then immediate past president of OSI, Dr. Manish Khaitan, who had a beautiful run as the president, and the incoming president of OSI, Dr. Randeep Wadhawan. All three are here. And then I'm also honored to have Dr. Nimeri as one of the panelists today. So I think we have a loaded panel, and what I'm going to do is I'll start my screen share. Are you able to see the slides? I hope so. Okay. So what are the challenges in bariatric surgery? And this is something which is so crucial because at the end, when we start a surgery, we also need to finish the surgery. And this used to be a challenge when I started bariatric surgery, that sometime I would say after 4 to 5 hours, we need to finish this surgery today. And those were the times when the energy devices were not very good, when the staplers were had 4 rows, when we did not have optical trocars, and any number of things. We did not have sevoflurane or desflurane. Patients were managed on halothane, and every patient would go to ICU on a ventilator. Those were the times. But over a period of time, things changed, the technology improved. And so we are going to talk today more about how the surgeons will manage the situation. I will run a video and then I'll ask my panelists what is their opinion. So this is my case mix, and as Dr. Nimeri, the number of Runway gastric bypasses are going up, and so are the revisions going up in our hands over a period of time. From doing almost 90% sleeve gastrectomies in 2013, we are now down to about 15% sleeve gastrectomy, and for various reasons which we can discuss at some other forum. So I'm going to play a video of one of the common things that we find when we are operating. And this is something that can happen with any surgeon. And this is these videos I have collated from different surgeons. The first one that I'm playing on the left side is our own video. And where during the last fire, you just saw that the stapler backed out. And when you see this, you should be careful because that means the stapler has not fired properly. And that is the time when you should see what has gone wrong. And for some reason, the video is short. But what has happened here at this part of the staple line has not been properly stapled, and this is going to bleed. I'll play another video, and as the videos are being played, I will start talking to the panelists. This video, as you can see, has been contributed by Dr. Randeep Wadhawan. And the best part is that these videos have come from different surgeons, and they are very open to talk about it publicly. And that shows the maturity of bariatric community in India. So this is where he is doing the stapling. And as he is going up, you can see that he's clearing up the crotch staples or the reinforcement that is being used. And as he goes up, these are all about 1 to 2 minute videos. So have patience and see them. He's seeing very clearly that nothing is coming from behind. And he see in the stapler, in the cartridge, he sees loose staples. And when he sees there he goes in. So Randeep, would you like to speak about it a bit? And as we discuss, as we see the video.
Yeah, so as you can appreciate here that the staple didn't fire, but the knife did go through. And there was a gaping hole in that, the sleeve that we were constructing. And so the first thing was just controlling the bleed there. The staple was of the adequate size. This was the body of the stomach. It was a blue cartridge that I was using here. And And it obviously, like it showed that probably something wrong with the stapler per se. And
Sorry. Please continue. I'll fast forward it. Yeah.
yeah. So obviously it didn't fire. And then what we did was we completed the sleeve, and thereafter we sutured this area. Now, another thing which probably is a take-home message here is that you don't really need to be extremely snug to the bougie there. If I was very snug, probably suturing here would have been a problem. But since I was just about loose there, I could easily suture it, of course, with the bougie inside, ensuring that I don't cause a narrowing. I actually did a seromuscular suture as well, so did a two-layered suturing, which personally, there's an old video, probably I would just carry on with a single layer presently. And like Professor Nimeri said, leak test is absolutely mandatory after doing any kind of procedure, particularly where you've had a gaping hole in the sleeve. So did a leak test there. And whatever it's worth, we also do a gastropexy, did a gastropexy after that. The patient did well, and we could send this patient home in 48 hours.
Okay, thank you. Mahendra, you have been doing bariatric surgeries for almost 20 plus years. How frequently do you see staple misfire, and would you manage it any differently than what has been shown by Randeep?
I think I had seen only one or two, and that too in my early phase when we were initial days we were using the staplers. But since last almost 15 years, I have not seen any staple misfire because I use only single time. So, and just what Randeep has done, I would have done the same. And if the sleeve is loose, I would have even taken the stay sutures and applied another stapler medial to it to have a complete stapled staple line, if the space permit.
Okay. So, Mahendra, what do you, you mentioned that for 15 years you have not seen it because you are not reusing a stapler. Is that the only reason why the staple misfires?
No, I think it is sometimes the technical problem of the device itself. So we have seen misfire even with the new cartridge also. So it's not that we have, but in sleeve gastrectomy, yes, I have not seen since last so many years.
Okay. Anybody, Manish, you want to add anything, or Dr. Nimeri, if you want to add anything to this?
Yes. I think we had only one stapler misfire, and that was a funny thing. I didn't notice it, but it was a teaching program. So I did a leak test, and I then came to know that there is a stapler misfire somewhere. So I just sutured it in a single layer. It was all done.
Okay. So I think we'll move on to we have about 10 videos to play. This is, so we have a collection of videos which have been contributed about the bougie leaks, bougie perforations. And this is something, again, like how Mahendra was saying, this was seen early in our career. But I find it, many surgeons are facing this. And you see, this is after a gastric bypass. The surgeon is looking behind because the bougie is not coming ahead. He's looking behind the GJ and he sees something, and then he goes up and here he sees the plastic or the rubber, as you say. And this has been done when a pouch has been created and the GJ has been done. So I think a very important message is, don't let the anesthetist withdraw the bougie immediately if it is not coming in, because if the bowel has been perforated somewhere, it's better that we see the perforation rather than if the bougie gets withdrawn and it's not seen. So, Mahendra, you want to say anything about this particular video?
Right, I had seen similar complication in one of my patients where I was operating in some workshop in Coimbatore, and I asked my anesthetist to pass bougie. She said, yes, I'm passing, and after some time, but I can't see it. She said, it's already gone completely in. So bougie has reached up to pelvis, and it has perforated in the pouch from behind. So it is a possible cause. So when we tell my anesthetist, if you feel slightest difficulty in passing a bougie, just stop there and don't do it. Let us guide it. So when we guide them by lifting the pouch and we can see from behind and we can see the bougie being coming in, we can always guide and we can have a safe passage of bougie instead of just allowing it to blindly go in. So I had seen this and I just repaired it, taking the pouch up and we just sutured it using the endostage.
Manish, would you like to, Dr. Khaitan, would you like to speak about it? Because, this is something which is happening all across the country with anesthetists who are not proficient or not experienced in bariatric patients. So
See, I would suggest to Dr. Rahman, it is very clear with me, once we are operating with someone with a new place, I'm very skeptical about bougie, very, very skeptical about bougie. At every step I'm asking, even I was operating in Bangalore, where is the bougie now? Where is the bougie now? And I keep on thinking, and especially when I'm repairing a hiatus, I would not repair a hiatus until I have finished my surgery. So this is a complication which can be handled, but can be dreaded also, because this perforation is there in the stomach, in the pouch. But if it happens up somewhere in the esophagus, the things are going to be very, very difficult. So correctly said by Mahendra, if you feel the smallest resistance, don't push it. Please do push it. Otherwise, you are going to have a problem. Please don't do that.
So in this particular case, since there was a perforation and we see a band there, obviously the perforation has to be closed, but would you like to remove the band or you will leave it there?
See, the band has absolutely no role in the beginning because it is loose, and if you have not tightened it much, you can leave it. It is not going to create an obstruction and reopen the anastomosis. Absolutely not, if it is placed rightly. So there is no need to remove the band, but if you are not sure about it, you can remove it because you can't take a chance with the patient's post-operative outcomes.
Okay. Professor Nimeri, would you like to see this video? This has been contributed by a friend of mine. And
Right.
as Manish was saying that, if it's up in the esophagus and we are looking at a situation where bubbles are coming out and the surgeon is not sure where it's coming from. So how frequently, you have worked in Abu Dhabi and now in US, how frequently do you see esophageal or bougie related perforations in bariatric surgery?
So I think the bougie perforation is a major error in communication, and it can be prevented if the surgeon is very clear about their instructions. So I'll give you an example. So I usually tell the anesthesiologist, only put the bougie behind the upper mouth and don't push it down first. And then I tell them you cannot push the bougie unless you are looking at the screen. So typically, when someone is pushing the bougie, if they're looking down at the patient, they have no feedback, no visual feedback. So even when they have resistance, they will keep pushing. But if you tell them to watch the screen with you, and you tell them that one of the problems of this bougie is perforation, especially when they're new, passing it, the risk is lower. So typically, you as the surgeon need to know who's passing the bougie. If it's an experienced person who's done it a lot, the risk of perforation is rare because they know. But the most important thing is, just like it was said by Manish and by Mahendra, that they stop if there's resistance, but most importantly, that they need to look at the screen. And many times, I will have someone who's never passed the bougie before, and as soon as they see it on the screen, they slow down because they can see the movement. So it's important to have the anesthesiologist look at the screen with you while they're passing the bougie.
Yeah, I think excellent take-home message. Randeep, what would you say, if somebody who is not very good in esophageal surgeries, minimal access surgery, and is doing a sleeve gastrectomy and he sees a perforation as is seen on the left side in the lower esophagus, how does he manage this? If he is not experienced to mobilize the lower esophagus, And especially in an emergency situation like this, what should be the next step?
Yeah, so a few things. One regarding the bougie, just an extra point that there is an extra port which we've discussed it so many times. There's an extra port to inflate the balloon. So probably this was a balloon inflation over there.
Absolutely.
And sometimes the anesthetists don't know that. If it's a new anesthetist, they would not know. So just cut that, because we don't that extra port, because we don't do bands anymore. So that would probably avoid this. Secondly, call for help. That's extremely important. If you're not somebody who's doing upper GI surgeries regularly, here in this case, because it's a sleeve, I would close the esophagus, this perforation, and then also I would convert this into a Runway gastric bypass. I want to make it a low pressure system here. A sleeve with this kind of suturing there has higher propensity for a leak. So I would do both these things in this particular case.
I think that's a very good message, because getting help in a situation like this, trying to do a suturing or a mobilization when you are not very comfortable and you have a complication at hand, is inviting trouble. So always getting somebody who knows how to do, who is an upper GI surgeon, who can mobilize with you. Even if you are good, it's always better to have somebody with you in a complication situation. So we go to another very interesting video. This is a case of Runway gastric bypass, where I believe so, where jejunal division is done. And then mesenteric mobilization is being done by dividing the mesentery quite lower down. We used to do it when we are doing ileal interposition, and see how the surgeon is dividing it. And this can happen in any part of bariatric surgery, because you are dealing with short gastrics, you are so close to splenic vessels, and this is here. This is a division of a mesenteric. All right. Now watch the surgeon's left hand. How efficiently it moved in to control the bleed right at the beginning. If that had not happened, probably there will be a big pool of blood within few seconds, not minutes. And that hand is holding the bleeder. And now he's... So, Dr. Manish, these situations can happen with anybody.
Yeah.
What are the important points? Professor Nimeri spoke about prevention of bleeding, having gauze pieces and all, but in this situation, by the time you get your gauze pieces inside, it will be a very big pool.
Yeah, I had this situation 2 or 3 times in my career. And this is the same. Keep your cool, have experienced people supporting you as an assistant. And as soon as possible, the ports which are placed, use other ports. Just try to control the bleeding as fast as possible, and don't try to tie it immediately. Just control the bleeding, see where the bleeding is from there, and if you have applied the pressure on the bleeding, it has stopped, then you can start suturing it, and then you can take a suture on it. I think that works, and all the 3 times it has worked.
Okay. Mahendra, would you like to speak on this particular video?
Since it is my own video, I think you've seen the management, and I think one is, if it is a small, you can put a gauze piece and wait for some time. It is not blood is not getting collected, but the way it was coming up, I realized that it is better to control it. My left hand instrument, I just controlled it, and then we started controlling it by taking sutures. So I used endo stitch here, but because the common order is very difficult to use during such situation, because somebody has to hold that area, and then you take so both your hand has to be utilized just to hold the bleeding site. So what I have done is shown to you. And,
I know. So Professor Nimeri, would you like to give any quick points on this? How do you manage it? Because he used the endo stitch, but not everybody uses the endo stitch. So then you are short of one hand.
Sure. So I think initially, when you take the mesentery, you need to expose the bottom of the mesentery better. That's one. The second is, I totally agree what was done here. If you can grab the bleeding quickly with a grasper, that's usually the best case scenario. And then what you can do is have your assistant come and grab the same area from a different location, like from the top. And now you can have two hands and you can suture if you need to. But this was handled extremely well.
Yeah. Randeep, do you want to add anything?
Yeah, so absolutely right. So not everyone is as skillful as Mahendra as well. So yeah, so multiple ports may be required, additional ports may be required. So if one is grasping the forceps, maybe you need to make additional 5 mm ports just to ensure that you can suture it well. So that probably would be required. In my case, what I'm doing is I'm actually not cutting the mesentery. I'm doing by omega loop fashion by taking the jejunum up. So I don't actually divide the mesentery, but yes, these things can happen.
Yeah. So mesenteric division was very common when we were doing jejunostomy first, because we were not sure whether the rule limb will reach up there, so we would divide it further down, and this is a possibility. But I think, as Dr. Nimeri was saying, shifting the grasping side in the assistant's hand, give the surgeon two hands. But here Mahendra had the advantage of using endostitch, and he could get away with it. Another very interesting video, a patient of Runway gastric bypass. GJ has been done, it has been sutured. And as some surgeons routinely use a gastroscope to check the patency and to see the bleeding from inside, a gastroscope has been passed. Now we have seen some blunt things today, the blunt bougie, the balloon, and now the gastroscope. So we are not talking of pointed objects causing trauma. These are because of the angulation of the stomach and the intestine, a blunt tissue. Now the surgeon is waiting for the gastroscope to come, and he can see the gastroscope movement behind and see the gastroscope there. All right. Mahendra, would you like to talk again?
Yeah, and again, this is my video of my early days when I used to do endoscopy as a endoscope to pass through just to check the anastomosis. And I could see this perforation. The scope was projecting through the mesentery. I could see the black scope, which is unusual in such situation to be seen through the mesentery. So I had gone behind and I could see the full scope coming out and it has perforated the posterior wall of the pouch. And I just sutured it using again endostitch, and patient has done well. Nowadays, I don't use endoscope, but I use bougie just to check the anastomosis. And so far after that, I never had any such injury.
Okay. So if I can ask you, was this perforation the reason to change from endoscope? Because a lot of young surgeons come and say, Dr. X, Dr. Y are doing endoscopy. Why we are not doing endoscopy after every patient?
Yeah, I think this was the only reason I stopped. And one is that it was narrow, which has more risk of perforating than a wider bougie, because endoscope is maybe 11 millimeter in diameter. Endoscope, the bougie is much wider size. So I think the chance of perforation is much less.
Okay. Anybody has any comment to add about using a gastroscope for leak test versus using a bougie? Please unmute yourself, otherwise we can move to the next video. All right. So these were the videos which were perioperative challenges. I have few brief ones on complications as such, which can take a whole night if you want to cover. But I can quickly run through one or two. This is a patient who had a port side hernia and the rule limb went in, and as you can see, it was a partial incarceration of the rule limb, and that was pulled out because patient was in obstruction, and CT showed the rule limb going into the hernia defect. And obviously this is something that is discussed on various forums, that if you have an open hernia defect, it's better to close it, whether you close it with suturing, preferably with suturing, or if you are comfortable using a mesh, then use a mesh. Otherwise, preferably suture close it so that such a situation doesn't arise. I will move to the next one. This is one of our patients. It's not very clear, but I'll just run. This is a gastroscopy being done in a patient 1 month after a sleeve gastrectomy, and patient who had difficulty and got a ultrasound done, which was normal, but then got a CT done in another country, and CT showed an abscess, peri-sleeve abscess. And then we went in to see this endoscopy. And when we were coming out, we saw this pus coming in, all right, from the abscess cavity into the sleeve lumen. So when you have a situation with a communicating abscess into the sleeve, and there is no fistula, no cutaneous fistula, and patient is absolutely stable. This is 2014. We are now almost 8 years later, and we have many endoscopic management. So I'll start with the Professor Nimeri. What would be your next advice to the patient, Professor?
So how sick is the patient clinically?
Patient is absolutely comfortable. Absolutely no fever. Patient is walking, moving around. Patient had a discomfort, severe discomfort in that area. Was actually in Middle East, and got a CT done there, and that's how she got to know that she has an abscess and flew back. That's when we did this endoscopy.
Right. So typically when there's a collection, the first thing I do CT guided drainage, and I send the amylase, the fluid for salivary amylase, and then we do an upper GI study.
Okay. And that would be all, or would you like to start some nutrition, enteral nutrition, or would you like to put an NG tube in this patient?
Sure. So definitely IV antibiotics, resuscitation, and I did not see in the endoscopy. Was there any stricture in the?
No.
No stricture. Yeah. So if you can place a nasojejunal feeding tube, definitely that will improve in nutrition.
Okay. Randeep, would you like to suggest something else in view of more recent developments, like putting a double J?
Yes, exactly. So I personally don't have an experience of this, but there is enough, there's some data to suggest, particularly published by Donatelli et al., that they've been putting these double J stents into that lumen. So if the size of that, the leak from the stomach is less than 6 millimeters, and you put in these stents, they actually drain into the stomach, and in a period of 3 weeks, they generally dry out, and you would not require anything more. Sometimes in check endoscopy, you may still find a little hole where you may need to put an Ovesco clip after that. But by and large, less than 6 millimeter holes, they'll probably not require anything else except drainage with a double J tube. Okay. And probably a nasojejunal tube for feeding. Yes.
Okay. Manish, would you like to add anything?
No, nothing, sir. I think I will go with whatever Randeep is saying. Feeding has to be established. That is most important.
All right.
And stable so.
Okay, Mahendra.
Yeah, I think such leaks are very rare to heal because of the high pressure of the tube, the sleeve tube. We have seen such leaks lasting for years and months, which last, and if it lasts, naturally the quality of life is not good. So, I mean, my personal view, I would have converted it to Runway gastric bypass with a jejunal patch, because patient is stable, he is fit to undergoing the revision surgery.
Yeah.
Technically, it is very difficult to do it.
Yeah.
So I think the option of putting a double J stent and wait for some time is acceptable, provided we can take care of nutrition so well. These patients may go into catabolism if the nutrition is not taken care, and they may have protein deficiency, and healing is a problem.
Yeah. So I think this is a major issue, because this was a contained abscess. Patient was absolutely stable, and conversion to a Runway gastric bypass in presence of abscess is little controversial. But Now that double J stents are there, if they were put in, an abscess can shrink in time. That's a good option, even better probably than the CT guided drainage. It depends on the facilities that are available for endoscopic DJ stent placement, because many gastroenterologists are themselves not very conversant with these newer things. So this is a very small video. I'll play it. This is basically a situation where the patient was having pain, and then the surgeon went in and found this, the candy cane part was sort of necrosed, and thus separation was done, and this necrosed part was excised, and that was suture stapled and closed. Manish, would you like to speak about this video?
Yeah, this is my video only. This patient underwent a RYGB with a lap cholecystectomy. Patient was only one problem. The patient was having pain. The CT was normal. Everything was okay, but the patient was not comfortable. So on second day, we just went inside and we found this necrosed tip. So we had a small candy cane, so we were able to excise it and patient did well.
Yeah. So, as Professor Nimeri was saying, if in doubt, go in and see, because these are the things which may not be picked up even on CT scan. And
in fact, there was one video I lacked, Raman. There was a patient who was absolutely otherwise surgically normal. 2 CT scans were normal. Yeah. But I was not comfortable with the patient's face and the patient's parameters. So we went inside and we found a 40 centimeters of Runway length, and absolutely normal surgery. Totally went into, it was black, and we didn't had a video to send it to you. So it was a very sorry state of affairs from our side. So we went inside, we excised it, and then patient and CT scan was normal because there was no leak, no air, nothing, whatever you say, but only had pain. So we went inside, we just excised that 40 centimeters, do a refashioned GJ, and patient was on.
Okay, thank you.
I mean, I would have to echo what Manish said. I mean, this patient, if not taken care of now, they will present 2 weeks later with a large perforation, or a few days later with a large perforation. So this is really a testament to early detection and early management, better outcomes.
Okay.
So Dr. Rahman, just one last point. This is, I think, this needs to be emphasized what Professor Nimeri said in his talk, that diagnostic laparoscopy is just another investigation which needs to be mentioned. CT scan normal, you still mentioned that there's one more investigation we need to do and then move forwards. So I think that's extremely important and a good take-home message.
Okay. Randeep, I think I have 1 or 2 questions for you for your video. Manisha is asking, why were you using harmonic to stop bleeding when you had the staple misfire?
Yeah, good question. So actually, there was just a small bleed. There was one bleed which was coming in. I had the harmonic in hand, so just held up with the harmonic and buzzed it. So nothing more than that. Yes, you could have used a bipolar or you could have used a suture as well, but just use a harmonic. And we know that, using the harmonic for a few pulses is not going to cause too much of necrosis, or, you're not cutting that tissue. You're just ensuring hemostasis there.
Okay. I have another question from, again, Manisha asking, Dr. Manish, was that a mesenteric vascular thrombosis, what we saw in the video?
No, it was not vascular thrombosis. We reviewed the previous video completely. It was absolutely normal. It is just one of those chances your days are not good.
Okay. So
just to diagnose early, go early, and a negative laparoscopy is not going to do anything.
All right. I think we don't need to discuss sleeve leaks because that's entirely separate discussion point. But this is one of the patients where there is a gross contamination after a sleeve leak, and it's high up, as you can see at the OG junction. And this is a situation. Mahendra, you were talking about conversion to gastric bypass. If you have a sleeve leak like this, and obviously it's contaminated abdomen, it's at least 5 to 7 days after a leak. So what would you do in this situation? Mahendra, are you still there?
I said in any situation, I would have converted this into Runway gastric bypass. In fact, all my sleeves, whenever I had seen leak, that to my initial first 100 cases, I converted to gastric bypass, and I presented those videos to consensus meeting in New York by Michelle Garnier, and everybody was shocked to see such videos, and there was a lot of discussion, and people were firing me, why you converted such videos, such surgeries to Runway gastric bypass. And when I sent this paper for publication, even Obesity Surgery Journal has not accepted it as a mode of treatment to treat a leak of sleeve at that time. So I don't have that publication, but any bypass, I'm more than happy to do conversion to Runway gastric bypass, and I'll always do a feeding gastrostomy.
So Mahendra, you can send it to Journal of Bariatric Surgery, and we can look at it.
I can. It was 2009. Yeah.
Yeah, Professor Nimeri, do you have? I mean, first thing is, would you like to talk about this conversion to Runway gastric bypass, and a case like this with sleeve leak with gross contamination? What would be your management strategy?
So typically, I try my best not to do sleeve leak conversion urgently. And the reason is not only because the patients might not be ready from a physical standpoint, but psychologically, the patient and their family might not be ready. So typically, when patients have a sleeve leak, I usually will place a jejunostomy feeding tube to make sure that their nutrition stays, or a nasojejunal feeding tube, until we make sure that on endoscopy there's no stricture. We make sure their albumin is more than 3, and that they understand what the next step is. And for most patients with a sleeve leak, I end up operating on them when they're several weeks after the leak rather than initially. So I send them home with the jejunostomy feeding tube, and I try to see what happens to them. And typically my preferred operation is, because they have a chronic fistula, is Runway esophagojejunostomy. I do it in retrocolic fashion, retrocolic, retrogastric, and it usually works very well.
Okay, thank you. Manish, do you want to add anything, or Randeep?
This is, I think, again, my case, it is after 2 months.
Yeah.
Hopefully, it was after 2 months. And it was very contained. So I did the same what Mahendra said. I went inside, and the patient's albumin levels and everything was good. So I converted into a gastrojejunostomy, not with a feeding jejunostomy, but with feeding gastrostomy, because I wanted to use the duodenum for maximum absorption, and this patient did very well, very well. The leak healed. I put a drainage tube, and the leak completely healed, and patient is doing.
So would you do a feeding gastrostomy in the remnant sleeve part?
Yeah, I did a feeding gastrostomy. There are 2 instances where I did a feeding gastrostomy in the remnant part, pushed the malacots. I didn't put some Foley's, put some malacot, and just push it, it went into the duodenum. So it compresses your JJ area also. It acts as a rise tube only. It decompresses your JJ area. I kept it open for 4 days. After 4 days, I put some dye into it, saw it, everything was all right, and started feeding the patient. I used to give him a lot of proteins, and the drain was there, and everything went well, and it went into a controlled fistula. And after that, I slowly started withdrawing the drain, 1 centimeters after 4 weeks, 1 centimeter every week, and it completely hit.
Yeah. So I would like to tell people who are not that experienced that it's better to be conservative, as Professor Nimeri was saying. If you're very well experienced, then you can manage the way Dr. Manish and Dr. Narwaria manages, because you need to have that kind of resilience to handle the friable tissue when you convert it into Roux-en-Y gastric bypass and doing a feeding gastrostomy. Everything is quite demanding in a redo surgery in an emergency setup. So fair enough. We move. Randeep, you want to say anything?
Yeah, so I would just like to add in these sleeve leaks, like it was mentioned, draining the abdomen well, putting in drains, nasojejunal feeding jejunostomy, extremely important. And there is a role of stents as well. So we've forgotten that there's a definite role of stents. These long stents, yes, people may argue that they can cause reflux, but at the same time, good 23 centimeters long stents can help before contemplating any kind of major surgical revisions. They should be given a try. And let's say if still the fistulas don't heal, maybe then one can consider any kind of a major surgical procedure.
Yeah, I think
Can I
that
add
completes.
stent? See, the long stent, the mega stent was really cumbersome, and I'd used it, and the quality of life was not good. But since this small stent with we call it beta stent, having 2 dumbbells, which will only occupy the space on both sides of the fistula, the site of the leak, and that will hold well there, and that can heal, and the quality of life is much better. There is no much reflux, and I used in 2 cases, and I was much comfortable using a smaller stent called beta stent, which has 2 dumbbells.
Okay, so Mahendra, you are comfortable with that stand? It doesn't migrate?
No, it has not migrated because the dumbbell one was going remaining above the G junction, and the second was going down. It is about 3-4 centimeters soft, which will take care of the fistula area.
Okay. Anybody has experience of dumbbell stent because though they are known.
It's called beta
I
stent.
had one experience of a dumbbell stand. I just came to know from Mahendra only, so I tried in one of my patients. The biggest problem is that the lower end of the dumbbell was below the fistula, but over a period of time, it made the fistula big. That was the biggest problem.
Yeah. Okay, so we quickly move to because we are running behind schedule. So this is a GJ leak, and as you can see, the leak has been suture closed, and then the surgeon is doing a feeding gastrostomy. So take home messages in leaks, Randeep.
Yeah, so this is a Roux-en-Y gastric bypass leak, and you can manage with closing the GJ leak as well as doing a feeding gastrostomy. But then if, like Professor Nimeri said, if it was a leak in OAGB, then it would be completely different because then we are looking at biliary leak there. So after, we may need to convert this into then a Roux-en-Y gastric bypass, or if somebody is not comfortable in Roux-en-Y, then maybe a bronze jejunostomy needs to be done, but ideally a Roux-en-Y along with closure of this leak if it's an OAGB. But RYGB, this is fine. Closure as well as a feeding gastrostomy.
Okay. I think we just have maybe, I just put this picture because, this is one of the commonest reasons for revisions in our practice. Patients with sleeve hiatus hernia, reflux esophagitis, and this is something where conversion to Roux-en-Y gastric bypass is a norm, and there's not much that we can do with any other procedure. So I'll close my screen share and thank all my panelists for the patience. I have one question. I can't leave this opportunity to speak to Dr. Nimeri in detail. I see a lot of surgeons doing long gastric bypass, Roux-en-Y, long pouch, Roux-en-Y gastric bypass. So they have become emboldened because of success of one anastomosis gastric bypass, and they say we don't have ulcers there. You just now presented very convincing data about a very small pouch, which we also prefer. So what will happen if people will have a long pouch Roux-en-Y gastric bypass? What is going to happen in long term with these patients?
I mean, I will start by saying that there is a randomized trial from the Netherlands, comparing a long to a short pouch, showing modest, better weight loss with the long pouch. But in that study, the PPI use was higher in the long pouch, and they did not comment on marginal ulcer. I will also say that for surgeons who perform one anastomosis gastric bypass often, they don't have a problem with bile reflux, but they have a problem with marginal ulcers. And if you scope patients, marginal ulcers after one anastomosis gastric bypass is a problem. So I suspect if you make the pouch long to technically make the Runway gastric bypass easier, you're going to have more marginal ulcers, in my opinion.
Okay, thank you. So thank you so much for all the panelists for contributing today, and I will hand over back to Professor Goel to take the proceedings further.
Thank you, Dr. Raman. I think today, I'm sure it has been lifetime experience shared in a span of about an hour or less than that. And I'm sure it's definitely a very troublesome situation for any bariatric surgeon, however young or however senior the bariatric surgeon be. And it's the amount of experience which matters in the efficient management of complications. And of course, the safe strategy to bail out the patient from someone else's complication, young surgeon's complication, becomes a huge responsibility of the senior bariatric surgeon. And of course, as you rightly mentioned, right time involvement of the other specialists, the interventional radiologists, interventional gastroenterologists, and probably one other senior surgeon to get out of the situation safely, the patient out of the crisis. And I'm sure this would have definitely evoken a thought process. And it was very honest when somebody was bold to tell there is a potential possibility somebody can die of a bariatric operation. And the way how people tell it subtly, starting from Professor Nimeri, Dr. Raman, and Narwaria sir, and I'm sure this will, in fact, has satisfied one other important aspect of what to tell to the patient. See, it is not the way how you convince, it is not the way how you push them for a surgery. It is for them to make a decision about surgery. This message was the most important of all the things for a young bariatric surgeon. And I'm sure every video had learning potentiality for practicing bariatric surgeon. Thank you very much, Professor Raman. Can I have the honor of inviting our National Secretary, Dr. Meeda sir, to formally propose the vote of thanks. Over to you, Meeda sir.
Good evening, everybody. So it was again a learning experience as usual. And I thank Professor Nimeri for giving his valuable time and sharing his knowledge. It's been a good learning evening for all of us. And thank you, our moderator, our past president, Dr. Ramon Goel, for moderating this panel discussion and sharing beautiful videos and giving practical tips. Each of the panelists, Dr. Khaitan, Dr. Narwaria, Dr. Wadhawan, and I also thank our president and Dr. Goel for being with us for this evening. So thank you once again, and good evening and good day to all of you. So see you again after 2 weeks for another good episode of learning in the IAGES Primetime.
Take care. Thank you. Good night.
Thank you, friends. Thank you, Dr. Lexus, for hosting a flawless platform. And I thank all the panelists individually and severally for making this evening a possibility. Thank you very much. And we look forward for yet another important IAGES academic activity in the near future. Good night and good morning.
Have a good weekend.